So this will be an overview about the state-of-the-art kind of MR imaging of the prostate. So this includes conventional MRI, spectroscopy. I'm going to speak a little bit about contrast-enhanced MRI and diffusion-weighted imaging also of the prostate. So first, some background information. So you probably know already that prostate cancer is pretty frequent now. It's the commonest non-cutaneous cancer in men now. It does kill a lot of patients. So approximately 30,000 people can die from prostate cancer or are expected to die in 2005. Approximately 230,000 new cases in the US. The staging, of course, is critical to any treatment decision and also critical for prognosis indicators. So most of the urologists will not use MRI because it's fairly poorly accessible or expensive. They will probably do staging using clinical criteria, but MRI is extremely helpful in terms of making decisions for treatment of prostate cancer, as you may see in the presentation. So the prostate has a conic-shaped appearance. It's called ice cream and cone appearance. So this is the cone, which is the peripheral zone, and the ice cream is on top, which is the central gland or central prostate. And what's important about the zonal anatomy of the prostate, you can see easily with MRI, is that more than 75% of cancers will arise in this region, in the peripheral zone, more than 75%. So that's extremely important to know. 20-25% arise in the central portions of the prostate. That's also extremely important to know. And also, I don't want to discourage you, but this is a very difficult location because it's mixed with BPH, and BPH has a very variable appearance and can be sometimes very difficult to diagnose cancer in the central gland. On top of that, urologists, when they do their biopsies for prostate cancer diagnosis, will usually not do biopsies of central gland. Usually they will do biopsies of peripheral zone and not use anything more deep than that unless you tell them. This is urethra in the middle. So the other thing important to know is that the transition zone, which is in pink here, is wrapped around the urethra, and this is what will give you BPH, basically, with age, basically. Normal size of prostate is about 20 to 25 cc's in volume. In young adults, of course, it can go higher after a certain age. So this is an axial schematic of the prostate in a young man. As I told you before, so peripheral zone will encompass 75 to 80% of cancer. Fortunately, it's not frequent in young people, but we see more and more now patients less than 50 years with prostate cancer. So probably related to more PSA detection and more awareness of this disease. So peripheral zone in young men is kind of thick. It has a high T2 signal. Okay, that's very important also to know. The central gland is kind of small in young people. As you grow older, BPH is kind of part of the normal aging of the prostate, of course, with different degrees. So you see here that the blue zone will hypertrophy, basically. This is the BPH, okay? And then this will compress the central zone, which will give you a pseudocapsule appearance on imaging. And this can also go so big that it can also sometimes more or less compress the peripheral zone. Some MRI T2-weighted images of normal anatomy to get started. Young to old, okay? So young, again, thick peripheral zone, bright on T2. This is a T2. All these images are T2-weighted sequences, coronal, no fat sat. Old patient, you see more BPH here with the urethra in the middle. You see nearly no peripheral zone. It's like virtual, completely compressed by nodules of BPH. And in middle-aged man, you see also some peripheral zone, also again, bright on T2, and some degree of BPH. And by the way, you see very nicely on the coronal images, the prostatic urethra and the membranous urethra here. So as you grow, basically we have gradual hyperplasia of transitional zone of the prostate. Another important thing to know is the peripheral zone extent. This is extremely important because I told you before that more than 75% of cancer arise in the peripheral zone, but you need to identify the peripheral zone accurately on your images. So when you look at the base of the prostate, there's no peripheral zone on top of the prostate. That's extremely important to know also. And this is a classic pitfall of some readers who are not really familiar with prostate will call, you see all these BPH, basically nodules at the base, we call it cancer. So there is no peripheral zone at the base. And sometimes, of course, you can have cancer in the central gland at the base. It happens, but you have to be aware of this pitfall. So again, peripheral zone usually sits posteriorly to the more central gland. And this is fortunate because this is where we're going to put the endorectal coil, and we're going to be in direct contact when you use endorectal protocol with the peripheral zone. So this is at the base, okay? Mid-gland, also, again, some peripheral zone, bright T2, the urethra here in the middle and the central gland. And as you go, so basically what happens is that there is no peripheral zone anteriorly, okay, as you may see here. It just wraps around for approximately half of the prostate. But around the apex, you're going to see that the peripheral zone is wrapping all around the urethra, so that's the difference. So in the apex, if you see something anterior, it could be cancer, could be coming from peripheral zone. So why do we need to use MRI in prostate cancer? It can be used to localize the cancer in patients with known prostate cancer. So basically, the usual scenario clinically, patient has high PSA or abnormal rectal examination, will get PSA detection, high PSA, will get a 6 biopsies done by the urologist under sonographic detection, and then that patient can have an MRI 3 to 6 weeks after the biopsy to avoid hemorrhage, of course, and then you can try to localize the cancer. You can try to estimate the volume of the tumor also, which could be possible prognostic indicator. You can also, there's a paper who showed that you can also estimate aggressiveness of the tumor using some spectroscopy criteria. The main indication, of course, is staging. Okay, so the main question that urologist will ask you is, can I operate the patient? Is it organ confined or is it going outside the gland? This is the main question. You can have to look for any extracapsular spread or invasion of seminal vesicles, nodes, bone metastases, or any other metastases that will make the patient inoperable. You can, of course, in patients who don't get any, who don't want to get operated or who cannot be operated for some reason because they have extracapsular disease or extraprostatic disease, you can guide and monitor treatment if they get radiation therapy or seed implantation using MRI. You can also use MRI to follow up patients after prostatectomy if they have any. So what happens after you remove the prostate, the PSA should be undetectable, should be 0, okay? If you have a PSA of 0.5 in a patient with prostatectomy, it's abnormal, okay? 0.5, 0.2 is abnormal. In those cases, can also benefit from MRI because you can detect any recurrence in the prostatic bed. The other indication that also appeared recently, and then we use it pretty frequently in our department, are anxious patients with high PSA and multiple negative biopsies. I have almost like 30 or 35 patients in my series now. And one of the patients had like 10 biopsies. So I was wondering whether any prostate was left after that. But so these patients and neurologists get anxious about missing a small occult cancer, basically. And then these patients can also benefit from MRI and spectroscopy and other modalities. So just like to remind you about the staging of prostate cancer. So we usually use the TNM classification now, and so it goes from 1 to 4. Unfortunately, we see sometimes patients with METs, but more and more patients get organ-confined disease now with PSA detection. So basically, you can operate patients with stage 1 and 2 because 1 is organ-confined that you don't see on imaging. 2 is something that you do see, but it's still organ-confined. 3 is a patient that cannot go to surgery. So the limit is between 2 and 3. And your role, the main role of MRI, is to detect the limit between 2 and 3. To say, oh, patient is not 2, he's 3. He has extracapsular disease or extraprostatic extension. If you see nodes, it's going to be 4. If you see any mets in the bone, it's going to be 4. And locally advanced, 3. Okay? So you should be able, with MR imaging, whether using conventional MRI with or without endorectal coil, to try to determine what's the stage, whether it's organ-confined, locally advanced, or metastatic disease. Of course, there's no real consensus on treatment because every patient is a patient, and there's no guidelines, general guidelines. But this is just a some kind of orientation for treatment. So most of the patients with organ-confined disease, whether you see it or don't see it on imaging, can benefit from surgery. Some patients refuse to have surgery because they don't want to get any risk for any side effect after surgery. They can get radiation therapy. And some patients with very small volume of tumor can get only what we call watchful waiting or observation, basically. So they get nothing, no treatment, and they get watched. They get follow-up PSA with doubling time of PSA, and they can get follow-up MRI. And if the tumor grows to a certain level, then you can get other options. When a patient has stage 3, meaning that he has extraprostatic disease, then there is no surgery involved. In general, surgery is not an option. However, in my institution, some surgeons are very aggressive, and even though there is a small extracapsular extension, they will go and do a resection. So it really depends. But general surgeons will not like to treat patients with extraprostatic disease. They will get radiation therapy, whether it's external radiation therapy or seed implantation. Patients with METs will benefit from systemic treatment, meaning hormone therapy, basically. We rarely use chemotherapy for prostate cancer. Usually it does respond very well to hormonal therapy. So the protocol we're using, so we have 2 types of protocol in our institution. So we have the regular, what we call the regular routine protocol, which involves using only the phase array coil, no endorectal coil involved, no spectroscopy. We just use the conventional imaging with some gadolinium and diffusion imaging. And the more heavy protocol involves using a pelvic phase array coil because you want to use spectroscopy and get spectroscopy. So this will really depend on the urologist. If urologist specifically asks for spectroscopy, then we'll do it, okay? So I would say approximately 2 to 3% only of our patients get spectroscopy because of reimbursement issues. We do probably 1 or 2 cases a week, approximately. So, but we do more without spectroscopy. So for the heavy protocol, the endorectal protocol, we use a combination of phase array, pelvic phase array wrap coil with the endorectal coil all together. After true phase, we have to make sure that the coil is well inserted. That's very important. It's essential. Whether it's too high or too low, or flipped right or left. And it takes me about like a month or 2 to train the fellows to insert the coil. I'm always happy when they do it well. So after that, we use a high-resolution T2. So this is the really basics for conventional MRI of the prostate. So we use axial T2, sagittal T2, coronal T2 without fat sat. You want to see the fat, okay? So never use a fat sat for the T2 because you want to see any extracapsular disease using the fat as a marker, basically, okay? Usually we tend to use a field of view of 14 to 16 centimeters. Physical coding should be right, left, very important. Otherwise, you're going to get artifacts in the prostate. You want to get artifacts on the side. And usually don't use parallel imaging or SENS. You can try, but in my experience, it's been very grainy because of a small field of view. So these sequences take a pretty long time, actually. So it takes about 3 minutes each, 2 to 4 minutes. So it's quite long. So you can always play around with the parameters, with the RECFOV. You can try eventually parallel imaging with your scanners if you want, but I think it's possible. But you have to make sure that you have a highly T2-weighted sequence and no fat saturation using small field of view and a 3 millimeter or 4 millimeter slice thickness. And then after that, we perform a T1 high resolution to match exactly the axial T2 to look for hemorrhage. That's mainly the main indication for T1 is really looking for hemorrhage and eventually looking for some bone mets, but it's small field of view. And then after that, we do an axial T1, but a large field of view. This is different from this. This is to look for nodes and bone mets. So this is a regular TSC or fast pinnacle T1, no fat sat. You can use fat sat if you want, and I don't use fat sat. And I usually cover from the aortic bifurcation down to the pubis, basically. And in this case, the phase coding should be AP because you don't want to get the artifacts on the side. You want to see the iliac vessels clean, basically to look for any nodes around the iliac vessels. So the optional sequence are spectroscopy, gadolinium. You can use gadolinium if you want, either using regular enhancement with 3 or 4 time points, or you can use also like a perfusion type sequence where you can use multiple time points. That's what we're using in our departments since recently. And you can use also diffusion weighted imaging, but all these 2 sequences are not really validated yet. There are some papers on gadolinium images for the last 2 years, but it's still work in progress, I would say. Diffusion imaging, same thing. Probably 1 or 2 papers in literature, a lot of abstracts in the MRI meetings, but nothing really definite. So I don't want to spend too much time in details about spectroscopy, but basically I just want to let you know that we use a 3D sequence called PRESS, or point resolved spectroscopy with chemical shift imaging. We have to turn off the phase array coil. We use only the endorectal coil. And the shimming is extremely important for spectroscopy. It takes sometimes 3 to 5 minutes, and you have to do a manual adjustment. And post-processing, I do it on the regular, workstation from, using Singo software, which is commercially available by Siemens, and you can use eventually Funk Tool for if you have GE. I think Philips has also a good software for post-processing. The acquisition time is about an hour for the patient, not including the post-processing, of course. So this is what you do for spectroscopy. So after you finish with all your conventional imaging, you're going to put a volume around the prostate, matching the size of the prostate as much as possible, putting some SAT bands around the prostate to make sure that you suppress all the fat around the prostate, which can contaminate the spectra. And then you're going to see a grid like this, like you do for the brain, where you can overlay your spectra with the conventional imaging, basically, and you're going to exactly know where you are in terms of spatial localization. And this is what you obtain. You're going to get, for instance, a slice here with spectra, and then you can click, for instance, on the voxel, and then you get a individual spectrum for that voxel. And so this is a normal-looking spectrum with a little bit of lipid contamination. This is one of the earliest patients we started 2 years ago. It looks much better now, usually. So you get a large peak at approximately 2.6 ppm, which is called the citrate peak, which is very specific for prostate. So I don't think that any other organ in the body will have such amounts of citrate. So we believe that citrate is involved in normal prostatic metabolism. So it's contained in sperm and in prostatic glands, basically. Choline is the marker. You probably know already that choline is the marker for cancer in the brain and in the breast. So in the brain, it's known for a long time now. In the breast, it's starting to be known. But for prostate, choline has been around now for almost 10 years now, or 9 years. So choline is high when you have cancer. Yeah. Anybody has a question? No? So this is what you obtain on the conventional images. So this is an axial T2, coronal T2, sagittal, axial T1, small field of view. This is the coil here in the rectum. This is the large field of view T1, where you can look for, detect any nodes. So the nodes usually, I spoke about that later on, but usually they're located in the obturator region, the iliac vessels. And this is about an hour. Sometimes a little bit over an hour and 5 minutes. So why do you need to use the endorectal coil? So this is all about 1.5 Tesla. So it's essential to use the endorectal coil if you want to do MR spectroscopy, at least for 1.5. Maybe for 3T it's going to be different. The papers that shown also better signal-to-noise ratio, better image quality, looking at the T2 images using the endorectal coil. It has, of course, disadvantages. It's not pleasant for the patient, and sometimes also for the person inserting the coil. You can get also some motion and near-field artifacts also because of the inhomogeneities, basically, because between the air and the soft tissue. Some people have been using fluid or water with some success. I don't use water because it makes it a little bit heavier, but you can try that if you want. But so this is the coil we're using for now. It's a Medrad coil. So it has an inflatable balloon here. At the end, it's disposable, and the cost is about $50. It's reimbursed by insurances usually. So this is the connector, goes into the main phase array coil, basically. So this is important to connect it to get signal from the anterior portion of the prostate when you're using conventional imaging. And this is something that can stop it from moving, basically. And usually you use 80 cc's of air, and positioning is extremely important. So what's the difference between MRI and spectroscopy? So MRI, or conventional MRI, is used for staging based on T2, actually. So cancer is defined, I want you to remember something, cancer is defined by low T2 signal in the background of bright T2 signal of peripheral zone. Okay, this is the main picture of prostate cancer. It's not always that simple, but low T2 signal. But the problem is that low T2 signal is highly non-specific because it can be seen in scarring, in prostatitis, hemorrhage, post-radiation changes, post-hormone therapy changes. So it's highly non-specific. And a lot of times you're going to see all these L-affine low T2 signal regions in patients with or without history of cancer. You don't know really what to do with it. So usually what I do when I read a prostate case, I always get I don't read the images, I read the whole case. So I get always the biopsy results, the PSA, the history of the patient. Did he get any treatment? Did he get any hormone therapy? So that's extremely important to read a case. So I learned to do prostate MRI at UCSF, which is a place where things were done like this. So we always get a folder with all the clinical information on the patient, and then you can give a consultation and a final impression on the patient. Okay, this is extremely important. So spectroscopy provides metabolic information on top of the anatomical information, and it can also increase your confidence in calling a region cancer, basically, if you know a little bit the technique and the limitations, of course. And spectroscopy is based on elevation of choline and decrease of citrate. So again, I would like to show you a normal spectrum. This is a normal spectrum showing you a very high choline, a very high citrate peak here, normal healthy prostate, whether you're using peripheral zone or non-peripheral zone, central gland. Small amount of choline is always normal. And there's a tiny peak here called creatine also, which is difficult to separate from the choline with the spatial resolution we have right now with 1.5T. Cancer would be the contrary, so citrate will disappear, basically. Citrate, again, is 2.6, so this is not citrate, okay? Usually the machine will label for you to make it easier, but you have to make sure to be critical and looking at peaks that are at the right location. You have to assign the peaks right location. So you see a huge amount of choline in this case, and this is a cancer, no citrate. And these ratios were described by John Kohanovitz from UCSF a long time ago now, 96. So, he used the ratio of choline to citrate, or most often you can use choline plus creatine to citrate because it's difficult to separate choline from creatine. And basically you're measuring the area under the curve of these peaks and you divide it. So in a healthy prostate, you have a lot of citrate, so the ratio would be very low. If you have cancer, the ratio would be higher, of course. And the limit is usually about 0.5, but this is only statistical. So I usually tend to call cancer above 0.5, 0.6. Okay. So this patient was like 75, and he had some remote history of high PSA and, cancer treated a long time ago, like 5 years before. And he had all this, I don't have the T2 images, but you see, behind that there is extensive low T2 signal in the prostate, so we're not sure whether it was residual, post-treatment changes with some stuff around the prostate that was probably residual extracapsular spread, or was it active disease? And spectroscopy was really helpful in this case because you see extensive choline peaks all over the place, meaning that there is active replication, active, multiplication of cancer in this case, and this was active, diffuse cancer, basically. So we think that we'd like to go back to choline. Choline is thought to represent cellular multiplication. It's not sure, but it's probably theory, but basically if you have more choline, whether it's in the breast or the brain or the prostate, you have more multiplication, and it's an indicator of cancer, basically. This is another case we had more recently in a gentleman where there was increased choline bilaterally also. You see there's a low T2 signal region here on the left. The right was more like bright, normal signal, so spectroscopy will also increase sensitivity, not only your confidence and your specificity, but also will increase sensitivity for detection. So regions that are isointense on T2 will be sometimes showing high amount of choline, which means that they can be also cancerous. And this case, this patient had bilateral involvement. And I just want to show you our preliminary experience with diffusion-weighted imaging. You see, the image quality is really not that good, but so diffusion-weighted imaging is that, again, for the brain, for stroke imaging. You're basing your diagnosis on restricted diffusion, basically. So the ADC would be, in theory, low in cancer. And you see clearly on this is an ADC map, basically. So you can measure the ADC, or the apparent diffusion coefficient, on this image. And you see the normal peripheral zone here has a normal bright signal, which is normal. And you see extensive cancer involving most of the left and portion of the right prostate here. So what are the MRI findings in stage T3 cancer? Again, I told you T3 means no surgery. So it's critical. If you're starting a program or starting to read prostates, the first step is really to identify T3 disease and T4, of course. And then you can go a little bit beyond that. So we're going to review all these illustrated by cases. So, for instance, this patient had a extensive tumor here. You see in the left peripheral zone, there's a TURP defect here. You see extensive low T2 signal, but you see also irregularities here in the left peripheral zone as opposed to this. This is more smooth here, but you see a lot of irregularities going outside the prostate into the fat. That's why you need to keep the fat also. And it's probably going also to the neurovascular bundles on the left. You see this is the normal neurovascular bundle on the right, which include the vessels and the nerves, and you see there's no there's a continuity between the neurovascular bundles and the soft tissue lesion. This is a T3 cancer, not operable. Another case here where you see on the right extension into the base of the prostate, extending into the seminal vascles. Another case here where you see also low T2 signal area in the right peripheral zone, mid-gland. This is very suspicious for cancer, of course. It's round, it's bulging, and it's going outside. So this is not a prostatitis or anything else. This is a cancer. And it's clearly also involving the right side and the neurovascular bundles on the right. And this patient is inoperable. Only if you have a crazy surgeon, but should not be operated. Another case here where you see also, again, NVB invasion, NVB on the right, normal, and on the left, extensive tumor here involving the left neurovascular bundles. So it's important to tell that to the surgeon, of course, because the patient will not go to surgery, but also to radiation oncology, let them know that there is extension which side, of course, but also which sextant. So usually I give always the reading on sextant location, right, left, base, apex, midgland. And if there's anything going outside, you should also specify the site of disease so that they can overtreat that region with seed implants or radiation. This is a little bit more subtle, where you see also, again, low T2 signal areas here in the left and also a bit in midline. But you see here, this is what we call the rectoprostatic angle. So this is the angle that's between the prostate and the rectum. It should be sharp angle containing fat. You don't see it on the left, so it's gone, it's obliterated. So this is also a sign of extracapsular spread of prostate cancer. This is a little bit more subtle also. This is a case I had probably a couple of months ago where a patient had proven cancer on the left. You see obviously a low T2 signal area here in the left peripheral zone, but there were some irregularities of the capsule here. See, it's a little bit, you see it very nicely here on the coronal image, and I call this actually on the report. I said there was extracapsular spread. The patient went to surgery anyway, and then this was confirmed by surgery also. And the patient, I don't know how he's going to be doing, but he got his prostate out. A little bit gross, so this is more easy to detect. You see obvious soft tissue tumor. Remember that seminal vesicles should be always bright on T2. They contain fluid, okay? If you see dark seminal vesicles, always be suspicious, but doesn't mean it's always tumor. It could be also hemorrhage, okay? So always match your T2 images with the T1 images. Make sure you're not calling something that's hemorrhage a tumor, okay? This is an obvious extensive seminal vesicle invasion, T3 cancer. So this is our case also with extensive tumor here going outside. You see a small node also here, likely it's pretty small, but it's probably very suspicious. And extensive colon metabolism also here. So the nodes are still a problem with prostate cancer, like they are probably also for bladder or for breast TA. So the location is usually in the pelvis, presacral, obturator, iliac nodes. What we use right now for it's the size, right? We use the size and the appearance on any cancer that you're looking at. So you're using the size. And you know that the size is not perfect, of course. Whether you're using a short axis 0.6 cm threshold or 1 cm, of course you're changing your sensitivity and specificity. If you're using a small threshold like 0.6, that's why I tend to use a 0.6 short axis. Your sensitivity is going to be pretty high. Specificity is going to be okay. If you use a 1 cm short axis threshold, then you're going to, of course, have a higher specificity, but you're going to miss a lot of, metastatic nodes. And usually my experience, this is really experience, speaking about the experience, is that I have to look at the volume of tumor also, whether it's on the MRI, spectroscopy, or the biopsy. If there's a small volume of tumor, if I see a node with the short axis between 0.6 and 0.7 or 0.8, I tend to undercall it. If the patient has a large volume of tumor, then even a node 0.6 cm short axis should be really noted and be specified to the surgeon, okay? If the patient has obvious, extracapsular spread or T3 disease, doesn't really matter anyway, because patients don't get surgery. But if a patient who is candidate for surgery and has a large volume of tumor, high Gleason score. If you see a node that's below 1 cm, you have to be careful about that also. So the other thing you can use, but you can't use yet, but they have it in Europe. Probably it's going to be FDA approved probably by early next year in the US. It's USPIO or iron oxide, small particles, ultra small particles. It's called Combidex. It's going to be called Combidex. It's sold by a small company in Boston, and they're waiting for FDA approval. So basically what happens is that you inject this USPIO through the blood, and these small iron oxide particles will go into the Kupffer cells of normal lymph nodes. And all the normal lymph nodes, whether they're small or large, will darken in signal. You can use a T2 star sequence, and you're going to get darkening of the normal nodes. And so this paper showed clearly and elegantly that USPIO has a sensitivity of 90% versus 35% for size criterion. So you can imagine how useful it's going to be, probably, at least in some patients, for bladder CA and prostate CA. So easy nodes here. You see a node here in the iliac, around the iliac vessels, two large nodes here on the left, on the right, I'm sorry. This case was recently, I recently read, where there was some prostate cancer, kind of large volume, and there was this tiny node that I really didn't, I just specified it in the body of the report. I didn't really call it suspicious, but it turned out to be, it was like 5 millimeters, very small. It was positive at histology. So this is just to show you that the size criterion is not perfect, okay? So we've been using diffusion weighted imaging for the last months now. Again, so this is a case I showed you, I think I showed you already. Sorry, so this is like a repeat. Okay, so now what about contrast enhancement? So there are like last couple of years, like at least like 5 to 10 papers talking about contrast enhancement. We know that prostate cancer is hypervascularized. It has new vessels. So it's a hypervascular tumor. And this was known a long time ago, probably, but a lot of centers who did a lot of prostate imaging didn't really emphasize enough on contrast, and now they're going back into that. So you can use contrast either as regular contrast with multiple time points or looking at the enhancement, but more sophisticated techniques can use perfusion imaging, and you can use some kind of models where you can get some parameters, perfusion parameters, very complex, that you can use also to identify tumors and also look for any changes after treatment. So this is a patient who had a large volume tumor in the apex with gland on the right, with some on the left also. Diffusion map shows also restricted diffusion more or less at the same region here on the ADC map. And you see an early brisk enhancement using contrast enhancement here. This is the quality is not the best because this is a turbo flash sequence where we privilege the temporal resolution over spatial resolution. So we have always the dilemma, like they do for the breast, where do we choose better spatial resolution, do we choose better temporal resolution? So for now, I'm choosing to get better temporal resolution. So I'm getting like 12 slices in 3 or 4 seconds, and repeating that over time for like 3 minutes to get perfusion data on the prostate. So, but still, you can see very nicely that there's brisk enhancement of the tumor also, as opposed to the normal peripheral zone on the left. Spectroscopy shows also, see the normal healthy prostate here with high citrate peak, and you lose that citrate peak on the right, and you see some choline starting to rise here. So ultimately, I think, at least probably in some academic centers, prostate cancer patients with high risk will benefit from all these modalities, basically from conventional imaging, diffusion, perfusion imaging, and eventually from spectroscopy. And you can give, like at the end, some kind of scoring where you can say where the tumor is, what's the volume, what's the risk eventually, and is there any risk of extracapsular disease or not. The same patient shows you again the enhancement, and this is just to show you a curve of enhancement, and you can try to quantify. This is a very simple quantification, just a visual. Then we can quantify that by using perfusion, parameters, and you see this, the ROI in the cancer and the ROI in the normal peripheral zone shows you obvious differences in enhancement. So you can use also, as I told you before, MRI and spectroscopy to diagnose recurrent prostate cancer after prostatectomy. So this is a recent case also we had within the last 6 months where the patient had prostatectomy and the PSA of 1 was abnormal. So, and then already you see on the sagittal images, this is a haze sequence, where you see something in there. There's like a low T2 signal soft tissue mass anterior to the bladder, to the base of the bladder at the level of the prostatectomy bed. This is a stir or T2 sequence where you see something in there, also round soft tissue mass that's a little bit low T2 signal. But then you see clear enhancement of that thing. So it's pre-contrast and this is post-contrast. So you see clear enhancement. So this is a recurrent prostate cancer. Yes? Yes. So prostate is gone by definition. So usually they will remove the prostate. Some surgeons will also remove the seminal vascule. Some will not. It really depends. So if you see seminal vascules after prostatectomy, don't be alarmed. Sometimes it's just because they left them in there. Because it was a small volume tumor, they just leave them in there. It really varies from patient and from surgeon to surgeon. So this patient, I think it was months after. I don't know. I thought like 6 months or something like that. So this is abnormal anyway. Whether you image, I mean, if you can image very early, you can see hematoma, you can see all those changes. But this is clearly not blood. It's a prostate, basically prostate tumor recurrence. The patient can be treated with radiation therapy after that. Another case also we had. This is more interesting because I was kind of puzzled by this case. When I read the case initially, I didn't have any clinical information. The patient wrote down, I had my prostate removed. And I was looking at the image, it looked like a prostate to me. It was pretty small for a prostate, so I thought he had some kind of TURP or some, but the patient turned out like he had robotic prostatectomy, robotic assisted prostatectomy. So we started doing that a year ago in our department, where we use these robotic instruments where you can palpate in 3 dimensions, basically. And so this is either recurrent or like left in place prostatic tumor, and this was clearly demonstrated also by spectroscopy, where you see also some colon peaks. Also, this was also a recurrent cancer in the prostatectomy bed after a prostatectomy. So there's a paper by people from Memorial that showed a nice paper showing that the range of tumors recurrence after prostatectomy range from 1 to 4.5 cm. It can be pretty large. PSA level can vary from 0 to 10. I'm not sure which patient had, white patient had, MRI with PSA level of 0, maybe clinically palpable. I don't remember. I read the paper some time ago. And in their experience, the tumors were hyperintense to adjacent pelvic muscles on T2. It was not our experience in the last 2 cases. So you can use also MRI to follow up treatment after seed implantation, brachytherapy. So this patient had prostate cancer on the right peripheral zone. This is a colon map. So you can use any color map, any coding to quantify the amount of colon. This is a colon map showing you cancer. And the patient had multiple seed implants, seen as these black holes everywhere. So it's interesting when you look at patients with seed implants, you can also localize the location of seed implants. So sometimes this patient can have weird locations like urethra. They can have seed implants in the neurovascular bundles also. So it's always embarrassing to say that in the report, but it could be the origin of the pain of the patient sometimes. And you see clearly that there's no colon left after seed implantation. Another patient we had also who had multiple seed implants in his, you see usually what happens when you use radiation therapy or seed implantation, the prostate shrinks down, and it's usually shut down basically by that treatment and gets very small, atrophic, fibrous, and low T2 signal. And it's extremely difficult to detect recurrent disease based on these findings. So imagine a dark background. It's very hard to see a dark tumor on top of that. So the only way to detect cancer recurrence in patients with radiation therapy is either spectroscopy or contrast enhancement, okay? So a patient has spectroscopy, and you see there's no metabolism, basically it's just flat. So this is called metabolic atrophy. The prostate shut down completely. So the 2 other options you're gonna see with spectroscopy in these cases with patients with recurrence PSA after radiation therapy is either, it could be metabolic atrophy, which is good. It could be also what we call metabolic recovery, where you're gonna see some citrate reappearing, which is normal, kind of. So there's the prostate is coming back to work, basically. And sometimes the worst scenario will be colon peaks, means that there is some cancer coming back. So I told you at the end that this indication is appearing more and more now. There are like a couple of papers recently, and it's been our experience also to have these men who have high PSA levels and multiple biopsies that are negative. And our only experience with 20 patients showed that spectroscopy only was had a very high negative predictive value, basically. So in other terms, if you see nothing on spectroscopy, you can really reassure the patient and say there's probably nothing. The PSA elevation is probably due to other etiologies, such as size of the prostate or BPH, and the accuracy was about 75%. You see here that the specificity, the sensitivity was 67%. So on like 20 patients, we diagnosed 2 or 3 cancers, which were completely undiagnosed by biopsies, so which is extremely interesting. But at the same time, we also had 2 or 3 false positive cases, especially in the central gland. So we think that spectroscopy is really potentially useful in this patient population. You have to know limitations. So again, I told you that low-T2 signal is highly non-specific, so don't rely on this only. And of course, if you have more experience, you're going to sometimes tell the difference between cancer and other things, but it's not always easy. There's a learning curve, of course, and sometimes subjective and subtle signs. We're not able with the current resolution at 1.5 at least to detect microscopic or small capsular invasions. Hemorrhage is also a big pitfall also, and I'll show you an example. And TZ, or central gland cancer, is also difficult to diagnose with spectroscopy, with conventional MRI, and also with spectroscopy. And you have to know some technical limitations for spectroscopy. So this is an interesting case. So a patient came in 2001 with prostate cancer. So you're reading the MRI, so where's the cancer, you think? Is it on the right, is it on the left, or is it both, or is it none? So you see low-T2 signal on the right and low-T2 signal on the left. How can you tell? Is there a way to tell on these images? Difficult. So if you were to use spectroscopy, you may be able to tell which one is which. So what happens is that a patient came back 2 years after that, and you see clearly that this region here is a little bit more prominent, and the rest is more like didn't really change. It's a little bit more atrophic. So this is like non-specific scarring, and this is the tumor, basically. So, but this shows you, gives you an example about how difficult low-T2 signal is alone. Okay, this patient also came after a biopsy, and where's the cancer? This is a T2-weighted sequence, axial. Difficult to know also, right? So there's like extensive low-T2 signal involving nearly the whole peripheral zone. There's some areas that's spared here. You have to look again at the T1 side by side, always. Okay, don't look at the T2 only. And you see the T1 corresponding images. You see that extensive hemorrhage is present on the left and midline. So all this region is probably just hemorrhage. It might be possible that there is some cancer beneath it, but you can't tell on the images. And of course, the right side is probably cancer because it's low T1 and low T2. Okay, so hemorrhage is an important pitfall. So that's why you need to really avoid doing spectroscopy or MRI immediately after the biopsy. You should do it at least 3 to 6 weeks after biopsies, or even that, or even before the biopsy if you can.
Why would hemorrhage affect spectroscopy?
Because the shimming is going to be very difficult. So shimming is difficult. You're going to get like a lot of contamination, a lot of artifacts, and also it's been described in one paper that there is choline leakage if you have hemorrhage. So what happens, there's like necrotic changes, and you can have some false elevation of choline. Sometimes you can get some good results. I have, occasionally patients who come from urologists that are stubborn. They don't want to hear, my advice. You just keep sending patients like a week after the biopsy or 3 days after the biopsy, ask for spectroscopy. I do spectroscopy without, big hopes, but sometimes I get some good spectra. But I'm always tell them at the end that it has to be taken with caution because it's really immediate after the biopsy. Memorial sloan kettering, they wait 8 weeks after a biopsy is done to do any imaging. So central gland cancer is, again, as I told you, very difficult to diagnose. This is a typical appearance here. It's not as easy as this, but this is like low T2 signal, kind of homogeneous looking in the central gland. You can call this BPH easily if you don't know it. The problem is if the patient has high PSA, the surgeon is going to go biopsy only the peripheral zone. He will never go that far because it's very anterior. He needs a longer needle. He will never do it unless you tell him, of course. And that's more complicated is that even if you do spectroscopy, you're not able to diagnose cancer in the central gland with a lot of confidence because there's lots of overlap with BPH and prostatitis. So this is really no man's land. It's still, a region that's difficult. Maybe with contrast enhancement might be a little bit easier. Spectroscopy has a number of limitations, as I told you. So shimming can be difficult. It's a failure rate of about 5 to 10% in best cases. It's costly. Accessibility is difficult. There are some false positives, again, especially in the central gland, BPH, prostatitis. This is a case I had recently. Also, patient had high PSA, very high, 20. Multiple negative biopsies. I do spectroscopy, you see elevation of choline all over the place, in the central gland especially, with very high ratios here. Okay, this is a zoomed, voxel. You see elevation of choline, there's no citrate. So I call this cancer. I was wrong. This was just stromal BPH. So this is a false positive of spectroscopy. But you cannot not call it. If usually what I do now when I'm looking for these patients with high PSA and negative biopsies, if I don't see anything in peripheral zone, I'm happy with that. If I see something in the central gland with some elevation of choline, I just have to call it, and I say probably BPH. But depending on this volume, if it's large volume, I say you should probably redo biopsy redirected by the spectroscopy. It's, of course, difficult to make sure that the surgeon is going to go exactly at the same place, but I try to help him as much as possible. And we're planning to do some kind of co-registration with some ultrasound device to make sure that they can look at exactly the same location. So I'm going to finish for like 5 minutes, and then we have 5 minutes for discussion. You can use, of course, MRI for non-prostate cancer applications. The main thing is prostate cancer, but you can use it for other things. This is, just a accidental appearance of a TURB defect on MRI. BPH, again, a very weird appearance. This patient had cancer, bilateral cancer, but also had weird-looking BPH with bright and dark signal T2. So the dark is usually stromal BPH or fibrous BPH. The bright signal is usually glandular hyperplasia. So you can have a mixture. You can have only bright or dark signal. And you can imagine that the cancer can be hiding somewhere here also or here. It's very hard sometimes. Patient in his 30s, a young patient who had hematospermia, came for an MRI to look for any abnormality, and he had this midline cyst with a fluid level with hemorrhage, basically. This is a T1, this is a T2. And you notice also that the bladder has some kind of diverticular appearance, and there's no seminal or hypoplasia of the left seminal vesicle. Further up, you're going to see there's one kidney missing. So this is a typical case of a Mullerian duct cyst with renal aplasia, basically. So some people call this also utricular cyst. There's no real difference between the two. There's only one paper that showed that utricular cysts are usually happening in more younger patients and a little bit more severe. Prostatitis, chronic prostatitis. Patient he was in his 30s, he had some kind of chronic pain, multiple episodes of infection, and you see a normal peripheral zone with normal thickness, but you see this ill-defined triangular shaped low T2 signal, not as low as cancer, kind of bilateral ill-defined. This is typical appearance for chronic prostatitis. If you were to do spectroscopy in this case, usually it's negative, basically. It shows you usually citrate peaks. However, there could be some overlap sometimes. So it's patchy, non-specific, and usually the T2 signal is less marked than in cancer. So I'm finished by showing you some new perspectives. So we're actively working, again, as I told you, on diffusion imaging, perfusion imaging of the prostate, improving spectroscopy imaging also. I'm currently investigating the use of the phase array coil only for spectroscopic imaging. And we just had our 3T system here. These are some images I had from my colleague from UCSF, GE system, 1.5 and 3T, same patient, see the increased signal-to-noise ratio almost doubled, basically, and you can achieve a better, spatial resolution. You can probably be better, more specific or sensitive about extracapsular spread. That's what we hope to achieve. Same patient had also spectroscopy, and you see, first of all, that the spectral resolution is much better. You see here the citrate peak is doublet, basically, which is a normal appearance. When you do ex vivo spectroscopy at high field level, you're going to see that the citrate is, in fact, multiple components. It's not like one peak. It has like 2 or 3 peaks. And you're able to see that with this spectroscopic sequence at 3T. And you have also better voxel size. So MRI of the prostate is, again, a multidisciplinary effort. You have to involve yourself with urologists, radiation oncologists, to make sure that and pathology, of course. It's I think ultimately it's going to be a combination of conventional. T2 is going to be probably the old-fashioned way to do prostate, but it's a good start. And functional imaging is going to be really important, so like spectroscopy and all the rest, and enhancement for cancer organization and staging, and its constant evolution. Okay, thank you.